everyone. I would like to welcome you to today's Systems for Action Research in Progress webinar. Our theme focuses on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. And the title for our presentation is Uncompensated Care Provision and the Implementation of Population Health Improvement Strategies. I'd like to go ahead and present the agenda for today's meeting. My name is Shauna Moore, and I am the Dissemination Director for the Robert Wood Johnson Systems for Action National Coordinating Center. We will start with introductions, then have our presentation and commentary, and end with discussion and questions. If you have a question or comment, please feel free to type it into the chat box in the lower left-hand portion of your screen at any time throughout the presentation, and questions and comments will be addressed at the end of the presentation. I would like to go ahead and introduce our presenters. C.B. Mamaril is a Research Assistant Professor for the Systems for Action National Coordinating Center. His research focuses on systems financing and economics. Dr. Mamaril received his PhD in Public Policy and Administration from the Martin School of Public Policy and Administration at the University of Kentucky. And our commentary speaker is Simone Singh, is an Assistant Professor of Health Management and Policy. Trained in accounting and finance, her research agenda focuses broadly on accounting practices and financial management strategies of both healthcare and public health organizations. Specific areas of interest include nonprofit hospitals' provision of community benefits, hospital public health partnerships around community health needs assessments and implementation planning, and financial and cost accounting strategies for both public health agencies. And now I would like to go ahead and hand over the microphone to CB.
Thank you, Shauna, for the introduction. Thank you also for those who joined us online for today's webinar. We appreciate your time and for registering and signing on, and thank you in advance to Simone, too, as well, for agreeing to serve as our commentator. Systems for Action is a national research program of the Robert Wood Johnson Foundation. We do want to acknowledge their funding and support for the center and for the research we do. This Research in Progress webinar series that we host here at the National Coordinating Center is designed to highlight research of RWJ S4A grantees, but for those who may not know, the National Coordinating Center also has its own intramural research agenda that is directed and led by our director, Dr. Glenn Mays. So our intramural research team appreciates the opportunity from time to time to be able to participate in this webinar series and share some of the research that we carry out here at the center, as this gives us the opportunity to get comments and feedback that we can use to improve and refine our analysis. And being able to obtain this early in the process is always very helpful. So we look forward to hearing from our commentator today and welcome any comments and suggestions that the audience may have at the end of our presentation. And any questions that we can't get to, we would be glad to reach out offline after the webinar. I also do want to acknowledge the help and contribution of my fellow intramural research team members, even if each of us does get assigned to lead the various intramural research projects. We do carry out each project as a team, so I do want to thank Nerlin Kuzanoff, John Poe, and Dominique Zafir for their invaluable inputs and assistance with this particular study. We also acknowledge the inputs and contributions we receive from researchers who have worked extensively or collaborated on our research projects, particularly those whose research have used the NLS-PHS dataset like Rachel Hograham and Rick Ingram. So for this intramural research project that I'll be presenting on today, it focuses on the work we are doing on examining the relationship between hospital provision of uncompensated care and how that might relate to hospital contributions to the implementation of population health improvement strategies as measured by hospital participation in core public health activities. So to start, we define hospital uncompensated care as an overall measure of hospital care provided for which no payment was received from the patient or insurer. Simply put, it is the sum of hospitals' bad debt and charity care. More specifically, if we were to separate it into these two components, a hospital is said to incur bad debt when it cannot obtain reimbursement for care provided. So for example, when patients are unable to pay their bills but do not apply for charity care or are unwilling to pay their bills. It should be noted that the way hospital uncompensated care is defined excludes other unfunded costs of care, such as underpayments from Medicare and Medicaid. The other type of component that makes up hospital uncompensated care, charity care, refers to care or service that hospitals provide without expecting to be reimbursed because they determine the patient's inability to pay. In practice, however, hospitals often have difficulty of distinguishing bad debt from charity care, and we'll speak to that issue a little more later. So why the interest in hospital uncompensated care? Well, for one, an often stated reason for ACA's passage was the rising burden on both patients and hospitals as a result of the uncompensated care for the uninsured. As we will illustrate in the next two slides, both the size and growth of this financial burden is quite substantial. Taken cumulatively since 2000, total uncompensated care is estimated at more than $500 billion. In terms of its growth, if we take the period between 1990 and 2013, we were seeing around a 6% average annual increase in hospital uncompensated care. So in light of the Affordable Care Act and Medicaid expansion, how would hospital uncompensated care relate to hospital contributions to population health improvement? Well, for one, policy rationale was that by expanding access to health insurance, that the ACA was expected to reduce demand for charity care. And with hospitals having less charity care demand due to coverage expansion, the expectation was that it might lead hospitals to reallocate resources to spend on community benefits, such as population health improvement initiatives. In terms of its impact on the level of hospital uncompensated care provision, so far the empirical evidence suggests that ACA Medicaid expansion has resulted in lowering the uncompensated care burden faced by hospitals. Most notably, work by Nick Pay and colleagues has shown that to be the case in Connecticut, and nationwide, particularly for Medicaid expansion states, as shown in the work by Dranove and colleagues. So this graph illustrates what we mentioned in the previous slide regarding the substantial annual increase in total hospital uncompensated care, and also reflects that decreasing trend in the uncompensated care associated with the post-ACA implementation period. So based on this annual American Hospital Association survey data, we see that the uncompensated care hit a peak of $46.4 billion in 2013. That number dropped to $42.8 billion in 2014 and to $35.7 billion in 2015. Interestingly, this data, which for 2016 covered some 4,840 registered community hospitals in the U.S., indicates an uptick in total uncompensated care, which rose to $38.3 billion in 2016. While we don't really know or have a definitive explanation yet for this uptick, some have suggested or speculated one contributing factor could be more patients with high deductible health plans that are unable to pay their hospital bills. In this graph, we see sort of the same trend in the second graph as we did in the first graph, with uncompensated care expressed as a percentage of total hospital operating expenses, where it peaks at 6.1% in 2012 and then followed by a significant decline to 4.2% in 2015, but remaining unchanged in 2016, which would imply that hospital operating expenses may have also risen proportionally. So like the examples just cited, past studies have looked at the impact of on hospital uncompensated care from policies related to patient and population insurance status and hospital-specific factors. Other studies have focused on the issues as they relate to defining, measuring, and reporting uncompensated care, especially dealing with delineating between bad debt and charity care. So as we mentioned earlier, where hospitals have historically struggled with accurately differentiating between what they report as bad debt and charity care, CMS has tried to improve the reliability of those reported values in the way they have designed and redesigned the worksheets and the CMS cost reports that hospitals fill out. So starting in 2003, Medicare required acute care hospitals to provide more detailed uncompensated care information in worksheet S10. Prior to that, only bad debt was reported in another worksheet. So they redesigned the worksheet S10 in 2006 and then again in 2010 to assist hospitals in better identifying and distinguishing between bad debt and charity care, including distinguishing between charity care provided to insured and uninsured patients. Another example of an issue related to this area too as well is that for hospitals qualifying for the disproportionate share hospital program that receives uncompensated care payments, CMS has proposed phasing in the use of uncompensated care data reported in worksheet S10, which could result in significant changes to the distribution of uncompensated care payments, whereas previously these payments were based mostly on the number of Medicaid dual eligible and disabled patients each hospital served. So there is some concern that these changes could have major implications for the financial positions of many hospitals that rely on these payments as an important source of financing uncompensated care. And for non-for-profit hospitals, these new CMS proposal sort of signals that an effort is being made to better align the uncompensated care values that a hospital reports via its Form 990 Schedule H with that reported in their CMS cost reports, which would in turn have implications obviously for a hospital's financial assistance policies and revenue cycle operations that include, among others, its collection accounting practices. And speaking of non-for-profit hospitals, several studies have examined their charity care policies that include, among others, their community benefit spending as an important source of investments in improving population health. So, not surprisingly, non-for-profit hospitals by design, with their tax-exempt status, spend more on charity care than for-profit hospitals. But apart from charity care costs, a study by our commentator, Simone Singh, and her colleagues using data from the IRS Form 990 Schedule H has found that non-for-profits spend about 7.5% of their operating budget on community benefit expenditures, of which, when broken down further, more than 85% goes to patient-recipient clinical services, 8% towards community benefits, such as community building and health improvement activities, and with the remaining 7% to support health research and education activities. All in all, Simone estimates that the community benefit expenditures represent an additional 9% in financial resources made available to the population health system. Also, using IRS data from 2010 to 2014, a study by Young and colleagues, which includes Simone Singh, found that the hospital community benefit spending over that time has remained relatively flat at around 7 to 8% of operating costs. In their study, they identified 7 types of community benefit spending, of which the first 2 of charity care and unreimbursed costs from government programs accounts for around 70% of total community benefit spending. So much of the extant literature has focused on community benefits as reported by non-for-profits on the IRS Form 990 schedule, but there is also research that has characterized hospital contributions in the form of hospital participation in the delivery of core public health activities. A study by Hogg Graham highlighted the important role that hospitals play in implementing population health improvement strategies. She found strong empirical evidence that hospital participation in the local public health system is associated with an increased overall availability and scope of public health services in local public health systems. And if we were to couple this finding to the empirical evidence that the population health system capital of a community is not just characterized by the level of public health spending, but also by increased availability and scope of population health services delivered through multi-sector networks, of which hospitals are a major factor, that these lead to improved population health outcomes. Given that what we know from the literature on the nature and trends in hospital uncompensated care and how they relate to hospital contributions to the population health systems, it leads us back to the question that we posed earlier, that if reducing the level of uncompensated care burden, would it free up hospitals to reallocate those resources that otherwise could be invested instead in the implementation of population health improvement strategies, sort of analogous to a substitution effect. So to empirically examine this relationship between hospital uncompensated care provision and hospital contributions to the population health system, we use a measure that is different from the typical measure of hospital contributions associated with community benefit spending from the IRS data, and that is the NLSPH's measures of hospital participation from the perspective of the public health system. So I'll spend the next few slides talking a little more about this measure, starting with the data source from which this measure is derived from, and that is the National Longitudinal Survey of Public Health Systems, or NLSPHS for short. Over a period of 20 years now, the NLSPHS has followed a cohort of some 500 communities with at least 100,000 residents, first administered in 1998 with a subsequent survey data collection waves in 2006, 2012, 2014, and most recently in 2016. Starting with the 2014 wave, the survey expanded sample to include another 500 communities with less than 100,000 population. And we are excited to announce that we are getting ready to soon launch a 2018 wave this year. For those who may not be familiar with the NLSPHS, it surveys local public health officials to report on the scope or availability of recommended population health activities based on the Institute of Medicine's core functions of assessment, policy development and assurance activities. The survey collects data on the population health network, particularly on the organizations contributing to each of these recommended public health activities. Data is also collected as it relates to the centrality of effort, as indicated by the contribution of the governmental public health agency. And lastly, the survey collects data on quality as it relates to the perceived effectiveness of each activity. So this table lists and summarizes the NLSPH's data collected in the scope of the population health systems as indicated by the availability of recommended population health activities. A cursory glance would show that overall availability of these recommended population health activities has increased over time from 64% in 1998 to 72% of these activities being available in 2016. Breaking this down further, one would note increases in both assessment type activities, such as those related to surveying communities for behavioral risk factors, and policy planning type activities, such as identifying and allocating resources based on the community health plan. However, we also note a reduction in the scope of assurance type activities, particularly those related to linking people to needed health and social services. This is notable since these type of activities are in this case, as indicated by these results, suggest an area of need that would be related to one of the priority areas of the S4A research agenda, which is to investigate the implementation and impact of strategies designed to achieve alignment, collaboration, synergy across delivery and financing systems. So, as part of our various intramural research projects here at the Center, we have linked the NLSPHS with several different data sets that have included, among others, the Area Health Resource File, the NACHO Profile Survey data, and for this particular analysis, data from the CMS Cost Reports and Impact File. So if you're interested in learning more about the NLSPHS, we invite you to visit the NLSPHS page on the Systems for Action website. We also derive from the NLSPHS a measure of comprehensive public health systems, which is one of RWJF's Culture of Health national metrics. In this measure, a community is characterized as having a comprehensive public health system when it has a broad scope of population health activities, a dense network of multi-sector relationships with contributing organizations, and central actors to coordinate actions. Based on this RWJF metric, it is estimated that some 40% of the U.S. population is covered by a comprehensive public health system. Speaking about organizations that make up the population health system, next to local health departments, hospitals represent the next largest contributor by implementing at least 47% of these recommended public health activities in 2016, which represents an increase of 26% from 1998, where hospitals were participating in only about 37% of the recommended activities. The increase in hospital involvement is made even more notable, if not critical, given that the results from the NLSPHS would suggest substantial reductions in the scope of contributions coming from several organizations that make up the population health system, including state public health agencies, other state government agencies, employer business groups, faith-based organizations, and other organizations. So using data from all 5 waves of the NLSPHS, this bar graph summarizes the scope of hospital participation in recommended population health activities by public health function, that is, hospital participation according to the implementation of assessment, policy, and assurance type activities. So if we observe that among the 3 functions of public health over time, hospitals are most likely to participate in assessment and policy activities, with hospitals' highest area of contribution being in policy activities, and where assurance type activities being the area where hospitals were consistently least likely to participate in. So this table gives us a more detailed breakdown across the 19 core population health activities that hospitals participated in between 1998 and 2016, as reported from the NLSPHS results, and which is also consistent with extant literature. We did find substantial hospital involvement in assessment activities related to conducting periodic assessments of community health status and needs, and investigating adverse health events, outbreaks, and hazards. For policy and planning activities, we find notable hospital involvement activities related to prioritizing community health needs, engaging community stakeholders in health improvement planning and maintaining a communication network among health-related organizations, coupled with the fact that we showed in an earlier slide where we observe a decrease in the scope of contributions of other organizations in the population health system. The increase in hospital participation in these types of policy and planning type activities also signal the growing role of hospitals as a central, if not leading actor in the delivery of these recommended population health activities. But just as it was with the results presented in an earlier slide, slide 9, an area of concern would be the decrease in hospital participation in the implementation of assurance activities related to linking people to needed health and social services. And just from a cursory glance, participation in assurance activities represent a significant gap in the population health system in which hospitals could be playing a more active role. Again, it is these types of assurance activities that represent an area of interest related to one of S4A's research priority areas on the implementation of strategies to achieve alignment and collaboration across delivery and financing systems. So, for this study, to examine the effects of changes in hospital uncompensated care on hospital contributions to the population health system, we linked the 2006, 2012, 2014, and 2016 waves of the NLS-PHS with data from CMS cost reports and impact files of general acute care and critical access hospitals, which we then aggregate up to the hospital service area. Our dependent variable is taken from the NLS-PHS, which is hospital participation in recommended public health activities. And our explanatory variable of interest or exposure treatment variable is hospital service area level uncompensated care costs expressed as a percentage of total operating costs. So we do panel regression estimation with instrumental variables methods that account for the endogenous explanatory variable, repeated measures, and clustering of public health jurisdiction within states. We instrument for uncompensated care using the community uninsured rate, a lagged DISH patient percentage variable, and a state Medicaid income eligibility threshold for children. Unit of analysis is at the local public health jurisdiction level, which can include multiple counties, merged with hospital service area level information on hospital uncompensated care provision. So in merging these two sets of data with different geographic identifiers, we design a weighting approach to account for overlapping county and hospital service area boundaries. So our analytical sample is comprised of 824 local health jurisdictions matched with some 1,051 hospital service areas. So this slide provides a list of the community level covariates that we include in our empirical model, along with a list of hospital service area level controls. The sample mean for our outcome variable of interest is, which is the scope of hospital participation in recommended public health activities, was around 41%. And the area level hospital bed weighted mean for uncompensated care costs for our sample was 4.2% of hospital operating expenses. So the box plots in this slide presents the IV regression estimates of the effect of changes in uncompensated care on hospital participation for the period between 2006 and 2016, as covered by our full panel. The coefficient estimates indicate an inverse relationship. Overall, the estimates suggest a 1 percentage point increase in the cost of uncompensated care provision as a percentage of hospital operating expenses is associated with a 2.9 percentage point reduction in the scope of recommended public health activities that hospitals participate in. We see a similar inverse relationship hold up when we also examine the impact of change in the uncompensated care provision on hospital participation according to and across the 3 public health function type of activities. So given the way the components of uncompensated care was being reported in the CMS cost reports and how they changed after 2010, we also wanted to see how results might differ if we restricted our analysis to cover the survey year periods between 2012 to 2016. And what we find is our results hold up in indicating the same inverse relationship for both overall hospital participation and across the 3 public health function types of activities. And for this particular time period, the IV coefficient estimate suggests a 1 percentage point increase in the cost of uncompensated care provision as a percentage of hospital operating expenses is associated with a 4 percentage point reduction in the scope of recommended public health activities that hospitals participate in. So looking at the same time period between 2012 and 2016, when CMS started to require hospitals to identify more clearly the cost of their charity care and bad debt, we've begun to take a first stab also at examining how the type of uncompensated care may affect hospital participation in these recommended public health activities, particularly because we're trying to find ways to also tie in our analysis with the extant literature on community benefit spending, which uses IRS data, given that it would also be interesting to see how well those data align with the charity care data reported in the CMS cost reports. And while these early preliminary results show the same inverse relationships, which for this particular analysis uses a total area level provision of charity care, the estimates are not statistically significant with the exception of policy type activities. But again, we're still early in this part of the analysis, so obviously we have to do additional investigation in this area. So to summarize, the preliminary results indicate that on average a 1 percentage point increase in uncompensated care costs as expressed as a percentage of hospital operating expenses is associated with a 3 to 4 percentage point decrease in hospital participation in the scope of recommended public health activities. We find the same association holds up even when we use our empirical model testing other measures of uncompensated care provision, including total hospital service area level uncompensated care costs and hospital service area per capita uncompensated care costs, among others. The results suggest that hospital participation in policy type public health activities, followed by assurance type activities, are particularly affected by changes in the hospital provision of uncompensated care. So given the evidence we have on system capital impact on population health outcomes, these results would lend to empirical evidence to inform the potential implications for population health, given the importance of hospital contributions to population health system capital. In other words, the results highlight the vital role that hospitals would play in the implementation of population health improvement strategies. So for next steps, we are also examining the effect of changes in uncompensated care provision on the level of hospital engagement in the public health system as measured by degree centrality, which measures connectedness of the hospital to the public health network, and betweenness centrality, which captures the extent to which hospital lies between other organizations in the public health network. And some of the results from the early analysis we've done suggest that there is evidence of reduced community engagement by hospitals attributable to higher uncompensated care costs. And like I mentioned earlier, we are also conducting further analysis that delineate effects on hospital participation attributable to hospital bad debt and charity care costs. And lastly, the results from this presentation analyze CMS cost reports data that was released late last year. And so CMS recently released an updated batch of cost reports late last month. And so we obviously want to see how our results hold up using the updated cost reports from CMS. So in the interest of time, I'll leave it here and I'll turn it over to you, Simone, for your comments.
Well, thank you, CB and Shauna, for the opportunity to comment on this really important and timely work. And I just want to, provide a little background and then also provide some, findings of a recent study we conducted using, as CB mentioned, some of the IRS reported the data that supports the IRS in terms of hospital community benefit spending, which is different to some extent from what CB and his colleagues have used. So the question that CB and his colleagues here have been exploring is one that's actually received a lot of attention in recent years from health policymakers, practitioners, and also the research community. As many of you probably know, under the ACA, hospitals' focus has really changed from focusing exclusively on clinical care within the walls of the hospital to broadening hospitals' perspective to the community served and the health needs of the population living in a hospital's neighborhood. And likewise, as CB mentioned as well, right, under the ACA, hospitals have experienced a significant decline in the number of uninsured patients, at least in many communities, not everywhere. And that was the direct result of insurance expansions in the ACA, most importantly, expansion of Medicaid. So the question that many have been asking really is, do hospitals that have experienced these declines in charity care and uncompensated care, do these hospitals spend these savings on other community health activities that may address some of the upstream determinants of health? And when the ACA was passed, and in the first few years, there was certainly a lot of hope among policymakers, practitioners, and researchers that would indeed be the case, that the idea being that there'd be reductions in uncompensated care, and that would free up resources that hospitals would be willing to invest in broader community health. And sort of just taking a step back, of course, there is no formal legal requirement that hospitals do that, neither at the state nor at the federal level. So we have, as you know, new IRS reporting requirements for hospitals in the Form 990 Schedule H. So hospitals have to report more detail on their community benefit activity, and that certainly has increased transparency and also fostered accountability of hospitals to provide some level of benefit to their communities, but there is no minimum, at least at the federal level, and in almost all states there's no minimum level. Also, the ACA's requirement that hospitals conduct these periodic community health needs assessments was expected to expand hospitals' focus really beyond the provision of clinical care and sort of beyond this within the walls of the hospital perspective toward really a deeper understanding of the underlying health status and the needs of the community. So what do we know about hospital community benefit activity in the years since the ACA was passed? So you may or may not have seen this article, which Gary Young and myself and a number of colleagues at Northeastern University have published earlier this year. And in this article, we look at spending by only nonprofit hospitals, using the IRS data on community benefit, and we found that pretty much community benefit spending hasn't changed very much yet, right? So we're looking at 2010 to 2014, and there was this slight increase that we find in overall spending, but it's not, dramatic in terms of the numbers, right? So we're seeing this slight increase from 7.6% of total operating expenses in 2010 to 8.1% in 2014. We also looked at the composition of spending, and what changed most dramatically really is, maybe not surprisingly, charity care. So the amount or the percentage of total spending that's focused on charity care has gone down, which isn't surprising given the insurance expansion, especially the Medicaid expansion that many states have implemented. What's been interesting to see for us is that direct spending on community health, so the fourth from the top here in the middle, has not changed at all. So at least in that first year of data that we had available at that point in time, we did not see any increase proportionately, right, in spending on these broader community health activities as charity care costs were coming down. And then we did a little bit more analysis based off of some regression analysis that showed that one of the driving factors, or one of the factors associated really with spending differences in hospitals' community benefit activity is sort of community level factors, how many community residents are insured or not insured. And so here we break it down by insurance status. So when we do that, we actually see a similar trade-off that CB and his colleagues have found using the data sets that CB has described and that are different from this one. So it's reassuring that we see the same or similar results using different data sets and different approaches. So here what we did was we divided hospitals in three groups based upon the uninsurance rates in the communities. So we have low uninsurance rates in hospitals in those communities on the left, and then in the middle, sort of hospitals in communities with sort of medium levels of uninsured residents, and then on the right we have hospitals in communities with high numbers of uninsured patients. And we can see here, first looking at those blue bars, right, that's the percent spent on charity care. So we can see that, of course, as the number of uninsured patient goes up, hospitals spend more on charity care, which isn't surprising. But what's interesting, though, is that looking at those yellow bars, you can see that hospitals in communities with fewer uninsured residents do spend more on these broader community health activities, are more involved, so to speak, in the public health system and in broad community health activities compared to hospitals in areas where there's just a lot of uninsured patients and where there's more demand for charity care. So these findings are consistent and really align, I think, nicely with what CB has presented in terms of this trade-off that we appear to be seeing between spending on charity care, clinical care, and spending or involvement more generally on in these areas of broader determinants of health, upstream determinants of health. So what are some explanations for this finding and maybe also CB's finding? Well, one likely explanation is that many hospitals probably have some sort of set or predetermined budget for community benefit and community health activities. And that could be both in terms of financial budget, right, but also in terms of the amount of staff they have available for these types of activities. So you could certainly see that, having a given amount of money, having a given amount of resources, both financially and in terms of, staffing, if you have to or if you want to address certain things such as clinical care, charity care more, right, that may crowd out or reduce what you have left in terms of staff and finances to do other things such as engage more broadly in the public health system and be involved in these broader community type activities. So given these budget constraints, hospitals may have to make choices as to what activities they can engage in. And certainly this study and CB study didn't do that either, but certainly we don't have any clear explanation, but that's one likely explanation. It's also consistent with what I've been hearing anecdotally from practitioners, but I know there's probably people on the call who have ideas or have comments on that as well, why we may be seeing some of that trade-off. I want to point out a couple of limitations and also suggestions with respect to CB's and his colleagues' work. First, I think one of the strengths really here is that CB, you have data, at least from what I understand, the data you use for hospital community, hospital charity care and hospital uncompensated care spending is really for all hospitals in a certain community, not just as we always have the limitation for not-for-profits. So that's really something we usually can't get to. The for-profits and the public hospitals, we don't have that kind of data because they don't have to report to the IRS on the 990, so we are always limited to the nonprofit. So that's certainly a strength. It gives a bigger, a broader, a more complete picture. One thing I want to point out, though, that CB, that your study certainly was doing is the unit of analysis of your study is the community, not the individual hospital. And I know it was necessary to do that, to aggregate to the community level because of the data that you have, right? Especially your dependent variable is at the community level. So these responses to the survey, as far as if I remember correctly, are from the perspective of the health officer, right, from the perspective of the public health system. And so it's for all hospitals in a community. And of course, that's why you also had to aggregate your spending for hospitals to the community level. I think, though, you have to be careful with respect to the conclusions you can draw because what you're seeing really is at the community level, not the hospital level. So at the community level, we're seeing this trade-off, right? So as a group, hospitals that experience higher levels of uncompensated care do less or are perceived by the health officer to do less in the public health system. But we don't really quite know what it's like for individual hospitals just because of the level of your analysis. And then I wanted to point out one last aspect, which you probably have thought about, but I don't think you've explicitly mentioned it here, which is the experience of hospitals in Medicaid expansion versus non-expansion states. And this graph is from an article that's currently under review that Gary Young and myself and others have been working on. Again, it's only IRS data, not the cost report data that CB used. But so what we find is that hospitals' experience in Medicaid expansion state is quite different from hospitals' experience in the non-expansion states, which kind of makes intuitive sense. And you kind of alluded to this also, CB, that of course in the expansion states, right, because of the higher number of Medicaid beneficiaries now, hospitals do see a significant reduction on average, not everybody, but on average, in uncompensated care costs. And this is shown here on our graph in that bluish line with the circles that's sort of at the top half of the graph. So we see here, especially between, so 4 here is 2013 and 5 is 2014. So we see this drop especially from 2013 to 2014, which makes sense given the expansion activity. And then in the non-expansion states, which is that orange-brown line just on top of it, that's hospitals and non-expansion states. We see that for those hospitals, uncompensated care costs, so both charity care and bad debt as reported on the IRS Form 990, has been fairly flat, if not even a little increasing. So one thing that we probably will be looking into, but that also be maybe something, CB, that you could look into, is just looking into differences in those communities that are located in expansion versus non-expansion states, and see how, if at all, you see differences in those hospitals' engagement in these broader public health and community health activities. So that was all I had to add. So looking forward to some discussion or questions and answers, and thank you very much for letting me comment on this work.
Thank you, Simone. I really appreciate your comments. And before I respond to those, I was hoping, Glenn, if you're on, maybe you could share a little more comments too as well to inform our discussion today. Anyway, I'll wait for Glenn if he's available. First of all, I just want to thank Simone again. There are two things. Simone, thank you for pointing out that it is indeed, we're looking at the public health perspective, so it is from the perspective of the the local health department official respondent, particularly in our survey, and how he perceives the activities that hospitals are participating in. And so we try to be as careful as possible, especially when we merge in these hospital service area aggregated measures of hospital uncompensated care provision, especially given the fact that the boundaries of these local health jurisdiction overlap with the hospital service area boundary. So in most cases, there really isn't a one-to-one match. So there could be counties that overlap multiple hospital service areas, or there could be a hospital service area that overlaps multiple local health jurisdictions. So we try to be careful with that, and we definitely use a weighting approach to try to control for that. Secondly, yes, we are also looking at the results, analyzing them according to Medicaid expansion states and non-Medicaid expansion states. So that's also another area that we're trying to account for also in our analysis.
Hey, CB, can you hear me?
I think, yeah. Yes. Go ahead, Dr. Mace.
Oh, great. I got unmuted. Thank you. So this is Glenn, and just a quick comment on that front. And again, Simone, thank you for your comments and suggestions on this work. I think, your instinct for kind of directions to take this are right on target. We have done some preliminary work looking at kind of the changing dynamics in expansion versus non-expansion states in terms of looking at the composition of organizations that contribute to population health activities, and we do see some pretty striking trends there with for hospitals, but also a range of other organizations becoming more involved in the kinds of population health activities that are measured in our survey. more involved, particularly in expansion states as compared to non-expansion. So that's definitely an area that we're going to do be drilling down in some more to look at how those basically how the composition of the networks of organizations that contribute to these activities, how they change differentially in these two different policy environments. So thank you so much.
All right, this is Shauna again. I want to say thank you to both Phoebe and Simone for reporting on this interesting subject. I'd like to go ahead and open up the forum for questions and discussion at this time. If you have a question or a comment, please type it into the lower left-hand chat box on your screen. I can go ahead and address one from Stacy. Did either study look at different types of hospitals or segments of the community to see if there were different results, such as children's hospitals or pediatric-focused services?
So you can go ahead first, Simone.
Sure. Yeah. Thank you. Our study, this work did not look at this specifically. We usually control in the regression analysis for certain, for certain factors. Children's hospitals sometimes we would control for typically things like teaching hospitals and size of the hospital, et cetera. These kind of more common variables or characteristics, system membership, location in a disproportionate, in a full community provider type status, etc. So yeah, we haven't looked at that. It might be something we could do definitely given the level of information we have, but we haven't done that.
Yeah, so neither did we in our study. It's just right now general acute care and critical access hospitals. It is, as Simone was noted, that sort of the difference also between our studies that we do look at not just for non-for-profits but also for-profit and government-owned hospitals that that file these Medicare cost reports. But no, we don't look at specific like children's hospitals or pediatric-focused services.
Okay.
And just
Oh yeah.
Oh, sorry. Just to jump in on that, we have done some work earlier to look at kind of hospital ownership and how that affects engagement in population health activities. In fact, a paper we published now almost 2 decades ago, looking at again on a hospital-specific level, those kind of contributions showed that not surprisingly, for-profit investor-owned hospitals tended to be less engaged in these kind of activities. We do want to take a closer look at that now in the kind of the post-ACA environment, because that's changed a lot of the both the kind of the market structure that exists around these hospitals as well as the policy environment. So that's another important dynamic to continue to watch in these studies.
All right, thank you. I can go ahead and open a discussion into what I believe to be an important part of this research, and that is the activity of linking people to needed health and social services, as it's one of the core items on the research agenda for the Systems to Action National Program. So I was wondering if you all could talk a little bit more about your preliminary results regarding the linkage and the impact of social services with your initial percent change outcomes from 98 to 2016. I'm just curious what may be incentivizing hospitals to participate more in these public health activities besides the decline in uncompensated care. Do you guys have any thoughts, maybe implications that were in the ACA, maybe a reduction in operating costs on average nationally, or any thoughts on that?
So I'd be curious to also ask Simone actually that, because I've never seen those IRS Form 990 Schedule H. As you said, I'm not sure, do hospitals sort of list down the type of activities that they consider like community benefit spending? So would they talk about like assurance type activities and so on? Have you seen that in the data, Simone?
No, on the 990, that's not the level of detail you would see. So what we look at in, for most of the studies we've done, when I say we, Gary Young and his team and myself included, usually we look at the community benefit spending that the IRS requires, which is these 7 categories, so charity care, Medicaid shortfall, subsidized health services, and then the broader stuff like community health improvement activities, which is just one line item there. So there's no additional additional explanation on the 990 for like what that means, what that includes, right? It could be all sorts of different activities that are broadly, community health, public health, right? So anything that you may see in your 20, types of activities may be something hospitals may or may not be doing and may be reporting in terms of, an expense, right, on their behalf. And then there are some, research and teaching activities that the IRS considers community benefit as well. So that's what we've been looking at. I think with respect to your question, I think why do hospitals do this more? I think there is I think having the resources available is one thing, right? Is important, right? To have the budget or have the manpower to engage in this more. I think the other thing is just that hospitals are realizing and are sort of pushed to realize, right, that clinical care is important, but certainly not the most important, or even it's not the most effective or efficient way, right, to improve population health. I think under DAC there are, especially for nonprofits, strong incentives with the needs assessment requirement to just get more involved in population health type activity and community health activity. Hospitals also have new reimbursement systems. They're members often now of ACO, so they are reimbursed based on value, not just fee-for-service anymore. So I think there's just this general sort of realization, right, that it doesn't just matter what we do to patients in our hospital, but it matters sort of how the community is doing. And so I think hospitals getting involved with different actors, right, not just the public health system, but others, community nonprofits and others as well, I think is important. I've done some other work that looks specifically at hospital and local health department interaction, and we do see that, for instance, hospitals that do a joint needs assessment with the local health department also have more health department participation representation in the implementation planning, right? So these hospitals do sort of more together, which is sort of a good thing. It's not required by the IRS, but that's another thing. So I think there's multiple factors certainly that lead to this, right? That hospitals have become more involved, at least from my perspective and from my research.
Yeah, and this is Glenn. I can add a few things as well. Again, as we've through our survey, the National Longitudinal Survey, we've been that's one of the measures we've been tracking over time is the extent to which organizations are contributing specifically to this activity of screening people for unmet health and social needs and then linking them to those who have those unmet health and social services needs, linking them to available services. And we see a couple of important trends in our data on that measure. One is overall, as CB showed, we've seen over time have a reduction in the proportion of organizations overall that are playing a role in that activity. And most of that reduction is actually, we see, is due to public health agencies over time getting out of that job. And partly, I would say in a large part, we see that has been driven by public health agencies over time that have reduced their activities in delivering clinical services. They're doing less, personal health services delivery. And that means there's less opportunity for them to be on a person-by-person basis screening and linking to services. But on the other hand, we've seen more recently, again, increases in other organizations playing a role in that linkage function, in particular hospitals and community health centers in our data. So there's there's a change in both in how much of this activity is occurring in communities and a change in who's doing it. And I think on the who's doing it side, I think there's been a number of activities that are leading more hospitals as well as more physicians and community health centers to be playing a larger role in this screening folks for unmet social needs and then linking them to it. I think that, for example, the hospital readmission reduction program that kicked in the mid 2012. Made many hospitals become more aware that these unmet social needs are part of what's driving people to be readmitted. And we've seen a number of national models emerge for how you do this screening and referral for unmet social needs, including the Health Leads program that RWF has supported, and now the accountable health community models that are being tested through a large-scale trial under CMS in about 45 communities. a primary component of those demonstration programs are screening Medicare and Medicaid beneficiaries for unmet social needs and then linking and referring them to those services. And that's especially driving, again, hospitals and clinical care providers to play a role there. So this is another really interesting phenomenon that's happening in the environment that is certainly relevant to these larger issues about community benefits and population health.
All right. I want to thank you all for your comments on that topic. We have actually one more question that we can get through, and that's from Emily. She is curious if the commentator had insight on how communities with stronger local regulations versus the IRS lack of required investment levels on community benefit investments compared to those where hospitals were left to their own devices to reallocate their potential uncompensated care savings back into the community. So I think this is a question for you, Simone.
Yeah, thank you. Are you aware of any specific local regulations? So I'm not aware of any specific local regulations that specifically ask hospitals to reallocate savings. I would be very curious to know if there are any out there. Typically, I mean, there are some local regulations. I mean, typically we have, in addition to federal regulation, when I said there is nothing, which there isn't in terms of how much you have to spend and how to allocate your spending. There are sometimes our state level regulations. So in some states, there are regulations that hospitals have to, for state tax exemption purposes, have to spend a certain amount or percentage of their operating expenses on, let's say, charity care or community benefit broadly, to remain tax exempt for the state purpose. That's only a handful of states. Texas, for instance, is one of them. I haven't seen, at least I'm not aware of any regulation that would say you have to reallocate, savings to, other areas. It's usually just like, do you meet a certain spending threshold? And often it's phrased in terms of charity care. So it will be interesting to see how, what these hospitals will be doing if they are seeing reductions. But Texas, for instance, is not a Medicaid expansion state, so they probably haven't seen that much of a reduction. But yeah, I'd be curious if you have any additional information on that. If you want to share, that'd be great. I haven't looked or seen anything like that.
Okay, well, that just about ends our time for today. I want to encourage individuals to reach out to the presenters if you have questions that were unanswered or that come up after this presentation. And also just spend the last few minutes giving you some information going forward. We would like to present you with a brief list of our upcoming webinars and direct you to our website for complete access to the slides from this presentation, including contact details for the presenters. And access to our webinar archives from past webinars under the News and Events section. We hope that you'll be able to join us for the next webinar, May 23rd, where we will hear about integrating cross-sectorial health and social services for the homeless. We encourage you to register at systemsforaction.org. We'd like to acknowledge that Systems for Action is a national program office of the Robert Wood Johnson Foundation and is a collaborative effort of the Center for Public Health Systems and Services Research in the College of Public Health and the Center for Poverty Research in the Gatton College of Business and Economics, administered by the University of Kentucky. I see that we are out of time. I want to thank everyone for their participation in today's webinar and hope to see you virtually in the future. Thank you very much.